Today I'm sitting down with Dr. Bob Watson. Right? He is the owner of Reno's first ketamine clinic. So thank you for sitting down with me today. Do you want to tell us a little bit about yourself, where we are, everything like that?
All right. Dr. Bob Watson. I trained as a surgeon, but was looking for a way out, and so moved into functional medicine, and along the way opened a ketamine clinic, the first ketamine clinic in Reno. We opened in 2017, and we initially opened under the name of Sierra Ketamine Clinics, but along the way, because I had two sides of the practice, it just made it easier to combine them under one roof. So now we do both under the moniker.
And you said functional medicine. What is that?
Functional medicine is really defined as getting to the root cause of why people are sick in the first place. The conventional model is using procedures or medications to address disease. Match a series of symptoms with a disease name, and then match that with a procedure or medications.
Like
and
the DSM and beyond?
For psychological, psychiatric disorders, yes. For acute care medicine, if you have a stroke, if you've been in a car accident, appendicitis, the like, then conventional medicine is very much the way to go, and I wouldn't have it any other way. But for chronic disease, high blood pressure, cognitive decline, diabetes, we do a really kind of a lousy job. And if you really look at the underlying biochemistry and physiology and understand why the patient's developing this illness in the first place, then there's a lot that you can do without requiring pharmaceuticals, to help that person get better.
So you operate a ketamine clinic, which everyone would say is a drug. So how is ketamine different than a traditional pharmaceutical, like any kind of antidepressant?
Well, it is a pharmaceutical. Okay. It is a drug. It just acts radically different than the antidepressants that are out there right now. It's a contentious area, and if you say that they don't work very well, some people will get very much up in arms.
The antidepressants don't work very well?
Right.
Okay.
And there have been some major studies comparing the efficacy of antidepressants to placebo. And I'm not sure we want to get into that.
I want to get into that.
Okay. But, in the year 2000, the first paper came out demonstrating ketamine's efficacy for treating depression, and it was considerably more effective. It's got a much more rapid onset. It turns around suicidal ideation pretty much immediately. And so since then, there have been a great number of studies, especially in the last decade or so, 5 years to a decade, that have really demonstrated ketamine's efficacy for depression, anxiety, PTSD, etc. And I'm sure Big Pharma is scrambling to look at other medications that don't require, that are easier to administer than ketamine.
Yeah.
But ketamine is incredibly effective, and that's where it's different than the other pharmaceuticals.
So most pharmaceuticals are the traditional line, but ketamine is going down the functional approach of figuring out what's actually wrong. Not figuring out what's wrong, but this helps the root of what is wrong, where antidepressants are almost just like a Band-Aid, would you say, for some patients?
I really separate ketamine from functional medicine, because while I really focus on helping people with disease get better from a root cause standpoint, and there's a lot that we can do for depression and anxiety from a root cause standpoint, but ketamine is really conventional model, pharmaceutical use of turning around a malady very quickly, very effectively.
So it's still the conventional model, but it blows the rest of the conventional models, antidepressants, all that, out of the water.
I think that's a reasonable statement, yes.
Reasonable, okay. How has your opinion on pharmaceuticals changed since you first started studying medicine, you became a surgeon, to now you have Reno's first ketamine clinic? How has your attitudes, understanding, and approach to classic pharmaceuticals changed?
I would say significantly.
Okay.
Because I trained in allopathic medicine, the conventional model. We're trained, basically everything comes down to a procedure or a pill.
Everything?
Most things. Most things,
okay.
Yeah. I would say like in excess of 90%. It's even when you read journal articles today and they're talking about a disease process, often it's what medicine can we invent or use to treat this disorder. And I can tell you that, as a physician, we get virtually no training, very little training in nutrition, and then beyond that week of nutrition, it's really not talked about again, and yet it's foundational to good health.
Yeah. Diet, exercise are the two big components that it seems like are always left out in the classic DSM model for at least mental health work. It's just, here's a pill, or here's this weird, strange therapy where if you sleep an extra 5 minutes, or if you do this one weird thing for 10 minutes a day, it's said to help. But this is different. Where have you seen the reliance of traditional pharmaceuticals fail?
Oh gosh. Left and right, really. I mean, they may provide some symptomatic relief, but the analogy would be, you come into your doctor and you're complaining of a pain in your foot. And the doctor's going to give you, an ibuprofen, a Tylenol, an opiate. But if you look at the foot and take the tack out, now you don't need those medicines, and it's kind of a silly analogy. Or the analogy would be, you look at a tree and the leaves are turning yellow. Well, paint the leaves green. That takes care of it, right? But it makes a lot more sense to figure out if there's a phosphorus or a nitrogen deficiency or an infection or too little or too much water. And that's the difference between conventional and functional medicine.
And so in the pharmaceutical approach to, let's just say, depression, historically, at least for the last probably 50 years, people thought that depression is because of a lack of serotonin or something involving serotonin, and if we can just bump up more serotonin, we can solve the depression, which is where SSRIs and everything like that comes from. How has that failed, and how are SSRIs not living up to actually fixing the root problem, but like you said, just painting the leaves green?
Yeah, well, it got started. There were a few drugs that bumped serotonin levels, and that's, I believe, where the idea that improving serotonin was going to fix depression came from, but that's long since been debunked. If it works, for example, once you start an antidepressant and you're increasing the serotonin levels to the synapses in the brain, then you would expect an immediate mood improvement, and we don't see that. It's well known that antidepressants typically take 4, 6, sometimes 8 weeks to really kick in, and that's if they're going to work. There are other mechanisms by which those antidepressants work for the people that they do work significantly for. But I can tell you that the majority of patients that come in to see me are on antidepressants, but they're coming to see me for ketamine therapy because even though they're scared to go off those medications aren't really doing what they need for them. So that whole serotonin idea has been perpetuated, but it's also been disproven.
Good. I had a friend in college, I was writing a research paper on psychedelics, shrooms for antidepressants, and she said she's been on antidepressants for years and has no faith of getting off it. She feels just hooked into it, and that's why we were working on it together. What makes ketamine different than the traditional SSRI in solving the problem?
It's a totally different mechanism, and so we can talk about how it works, or we can talk about its efficacy. I imagine we'll probably talk about both.
Yeah.
But in contrast to increasing serotonin or norepinephrine levels in the synapse or the space between nerves where the nerves talk to each other, ketamine acts on an entirely different receptor. It acts on an NMDA receptor. And it gets kind of convoluted, but actually, if you look at the brain, and you provide ketamine, you actually see an increase of glutamate. Glutamate is the most abundant excitatory neurotransmitter in the brain, and yet ketamine is what we call an antagonist, or it basically blocks the action of glutamate. So how does that make sense? It actually acts on inhibitory neurons. So when you block the action of the ketamine on an inhibitory neuron, now that inhibition is released, and so the nerves that it acts on then release more glutamate. And so that's the end mechanism. It really acts on AMPA receptors more, as far as the antidepressant effect. We also know that it stimulates a chemical in the brain called brain-derived neurotrophic factor, or BDNF for short.
Okay.
And what I tell my patients is just to think of brain fertilizer.
Okay.
What happens to your yard if you never fertilize the grass? It goes from green to yellow and eventually dead, right?
Yeah.
The same thing happens with depression. Depression isn't really so much a paucity of serotonin, it's multifactorial. But one of the things that we know is chronic stress or chronic cortisol exposure shuts down the production of this brain fertilizer. And so people are producing less of this growth factor, and so nerves in very important areas of the brain, specifically the prefrontal cortex, which is primarily responsible for planning or executive function, and the hippocampus, which is the memory function, and it's tied to multiple other areas of the brain, those nerves atrophy, they wither. And so what ketamine does, quite impressively, is cause a massive release of this brain-derived neurotrophic factor, and immediately those nerves start to regrow. We call that neuroplasticity, growth of nerves, rewiring of nerve circuits. It induces more synaptogenesis, so more of those talking points between the nerves. We also know that it calms inflammatory mediators or chemicals that are associated with inflammation that negatively impact how the brain works. So it's multimodal. It's neuroprotective. I mean, there's ketamine's even being looked at these days to address or possibly reverse, cognitive decline, like Alzheimer's disease.
Yeah. So it seems like the overload of stress makes people too rigid, and the ketamine allows them to be a little more flexible, if we want to put it in acceptance and commitment therapy terms, would you say?
I don't know the research on that. What I can say comfortably is that the chronic cortisol production or exposure shuts down brain-derived neurotrophic factor, areas of the brain atrophy, and ketamine reverses that immediately. Now, it's not in one infusion. One infusion, we see a varied response, but it's short-lived. So typically within half a week or a week, whatever benefit you derive from that ketamine infusion is going to be gone. But if you jump back in there within 3 or 4 days and provide another infusion, then we're stacking benefit upon benefit upon benefit. And with that, we get more and more duration out of the treatment.
So I see a lot of problems with antidepressants, people staying on it for life. Is this different? When do people stop ketamine therapy, and what's the process afterwards? Because if we're stacking it, when do we stop? And does it have any effect on people's, natural production of these chemicals, or what's the long-term play with it?
Okay, so in contrast to like the SSRIs, basically when you cause the brain to increase production of a chemical, in this case serotonin, the body is incredibly brilliant. I mean, beyond my comprehension.
Yeah.
But the brain is going to compensate, and so it's going to downregulate serotonin receptors, so you're essentially back to baseline within a short period of time. Then when you try to take that drug away, you've got to deal with the paucity of receptors. So there's essentially a withdrawal period, which is why stopping antidepressants cold turkey is not a good idea. You want to wean off them typically. Some people can wean off pretty expeditiously, and some people, I worked with a woman for nearly a year trying to get her off Lexapro, and she finally just gave up. So it's a significant issue.
Gave up as in?
In trying to wean off. She said
okay.
it was her second attempt at trying to wean off the medication, and she just finally resigned and said, I'm just going to be on this for the rest of my life. Ketamine, in contrast, very rapid response, but some type of maintenance is going to be necessary. So once they go through an induction series, and in our clinic, a lot of clinics start with a series of 6 infusions, 2, 3 a week for whatever time it takes them to get through those 6 infusions, 2 weeks, 3 weeks. But then some type of maintenance is going to be necessary because, as I said, after an induction series, you can expect that benefit to last for 4, 6, maybe 8 weeks. There have been studies of it lasting longer, but to minimize or reduce or eliminate that chance of backsliding and those old symptoms coming back, some type of maintenance is necessary. So a lot of clinics will have patients come back every 4 to 6 weeks for booster infusions.
And I think the important part to note is what makes your clinic different. You don't just focus only on ketamine, you integrate the functional approach to say focus on health, exercise, diet, all those things. And I guess, what's the whole process like? If someone called in today and said, I need ketamine therapy, what's their journey going to look like here?
So we start with a consultation. It's required to establish a patient-physician relationship. I use that consultation time to find out what's going on with them. Why are they showing up on my doorstep? And then the bulk of the consultation is spent with me educating them. What is ketamine? How does ketamine work? And then how to get the very most from those therapies. And I don't just focus on the pharmaceutical aspect, but the lifestyle aspect. So we don't spend a lot of time on the lifestyle, but I make sure that they understand that some of the biggest things that you can do is get off the standard American diet, get off sugar,
Yep.
and exercise. Exercise is one of the single biggest things that you can do to stimulate your own brain-derived neurotrophic factor. We all have it all the time. Now, some people have what are called single nucleotide polymorphisms or genetic variances. We all have these. But some people have SNPs, as we call them, that results in them producing less of this brain-derived neurotrophic factor. So some people are going to be more prone to depression or cognitive decline. But exercise is, there's so many things that exercise is good for. I often have patients come in and ask me about this supplement or that supplement, but they're not exercising. It's like, if you really want to move the needle, first clean up your diet and exercise. Make sure you're getting sleep, manage your stress, avoid the toxins. Then we can talk about supplements.
And would you say in the traditional model for, let's just say, depression, where it's here's an SSRI, in your history and your understanding, are those SSRIs usually coupled with the advice to work out and to clean up the diet? Or it's just like, no, here you go, here's the drug?
Well, I think you have a pretty good idea already. Doctors are under a lot of pressure to help their clients, and they need to do so in the typical 8-minute doctor visit. That doesn't involve a lot of time for counseling. And then sadly, a lot of physicians in the conventional medicine space poo-poo anything that doesn't involve procedures or pharmaceuticals. And I've had patients say, I asked my doctor if my diet has anything to do with what I'm suffering from, and he essentially scoffed at me. Like,
oh my God.
Like, don't be silly. No, but it's very common out there. And I can say that even when I practiced conventional medicine and before I learned about functional medicine, I had somewhat of an attitude about non-allopathic practices. I think I was a little more open-minded than a lot of my colleagues because I'd always studied the underlying physiology. It was my own personal goal to never have to take a pharmaceutical and to be very functional and agile at 80, 85 instead of the typical American, slow decline starting at your 40s, add a medication, add a couple medication, open your belt up a little bit bigger, and then by the time you're 60 and 70, severely limited in what you can do. It doesn't have to be that way.
And so you said not a lot of real counseling. Maybe if someone goes to a behavioral therapist or some kind of psychotherapist, they'll get that, but not just the traditional pharmaceutical model. When you guys have a patient under treatment, exposing them to ketamine, how much of it during that treatment, if it's an hour, is it an hour? Or how long are they under
the
that?
Infusions, they expect to be in the clinic for about an hour. The infusions themselves are 40 minutes.
Okay. During those 40 minutes, are you talking through how they're feeling and almost giving them, not talk therapy, but that clinical aspect?
That's a really great question. The truth is ketamine does most of the work. But I encourage every patient to have a talk therapist in place. Okay. And we prefer that they have a talk therapist in place before they come for ketamine. There are certain practitioners that are trained in helping people undergo psychedelic therapies or ketamine therapy. They're trained at helping the patient best prepare so that when they're in the dissociative space or under the influence of ketamine, that whatever happens in the brain happens to work better to their advantage. Yeah. And I can see a difference. But we don't force any counseling on the clients. And the truth is, in our clinic, well over 90% of the patients leave here saying it was a success, and the majority of them, sadly, don't have that counseling in place.
So you're saying most people who come to you are already on antidepressants. They feel like they're on antidepressants for life. Is this the last shot for most people, would you say, that come in?
We get a lot of people that feel like it's their last hope. And that's really, it's always concerning to us because there are some people that ketamine doesn't work for. As I said, while we have over 92, 93% success rate as determined by the client, not us. That implies what? 6, 7% feel like they get nothing. And if somebody comes in and they're hanging their last hope on ketamine's efficacy and they don't get that result, my concern is, what are they going to be left with afterwards?
Yeah.
So it's, fortunately, most people don't come in that desperate.
And do you think that the preparation for ketamine, where they tell you this is what you expect, these are some, I guess, mindfulness practices to have under your belt before going into it, do you think those, having that ready to go into the therapy, how much of that helps? Because you said ketamine does most of it, but how much of those skills themselves carry over outside of ketamine and are also, if we were going to do some kind of behavioral intervention, are good things just in general to have someone set up for, like accepting what's going to come, all of those kind of aspects?
I think it's very substantial. I think it's huge, which is, again, why even though I don't practice the counseling, I have a lot of faith in those that do, and I encourage every patient to have that in place. And we see the difference, in the patients when they have that therapy in place. Oftentimes the first couple of infusions can be less than ideally productive because the patient hasn't spent the time with a talk therapist kind of adequately mentally preparing, and that mental preparedness adds a lot to the potential benefit. I mean, if you're only going to say have 5 infusions, then you want everyone to be as productive as possible, and not spend the first couple kind of getting in the groove before you really start to see the benefit.
And you said people lump ketamine therapy into psychedelic therapy. So why would you say ketamine is slightly different than traditional psychedelics, or is it different?
It's different in that the mechanism in the brain is different. How it's administered is different. Ketamine, fortunately, well, I don't want to say fortunately, ketamine, fortunately in that there is a legal means of achieving the same outcome. We have psilocybin and MDMA, LSD all being looked at very scrupulously. MDA and psilocybin are the closest for looking at treatment of PTSD and depression and end-of-life anxiety and such, and they're proving to be very effective, and I'm very hopeful for what's coming down the pike. Right now, it just happens that ketamine is the only legal means, but it's very effective, and so we don't need to wait for other modalities to come online.
You're saying people need to have some sort of, I guess, expectation for what they're going into, and what are they getting into? It's not a psychedelic classically, but are people still hallucinating? Are they tripping balls? Like, what's the experience? What do people report back to you when they're in that experience?
Ketamine is known as a dissociative anesthetic, so everybody describes dissociation a little bit differently, but the patient tends to become a very active mind, but they essentially lose touch with their body. And when you realize that ketamine was invented as a general anesthetic, so that's one important thing to realize. Ketamine was invented in 1962 as a general anesthetic. It was approved in 1970 as a general anesthetic, and it continues to be used as such today, although it's not a first-line anesthetic. So it makes sense that patients would decrease feeling and essentially lose sensation or
I guess awareness of their body?
Yes.
Okay.
And yet their mind is very active. So for the first 5 minutes of an infusion, you're basically awake, and what we encourage patients to do is just relax and do their best to get in what we call a parasympathetic state. Parasympathetic, there's 2 sides of your autonomic nervous system, the part of your body that you don't consciously control. Sympathetic is the fight or flight. If you almost get by a bus, somebody points a gun at you, if a lion's chasing you, you're in a sympathetic state, and basically all systems in your body get shut down except for those meant to save your life at that moment. Okay, so you do not heal in a sympathetic state. In contrast, parasympathetic is rest, digest, sex, sleep, and heal. You heal in a parasympathetic state, and I believe you're going to be most receptive to the benefits of ketamine in a parasympathetic state.
So how do you get someone into that parasympathetic state?
It's really as simple, so there are some very mechanical ways of doing it. Big, deep breaths with slow sighs. If you put if we listen to your heart rate and we have you're ticking along, say 70 beats per minute, you take a big deep breath, and then a nice slow exhale, you can actually listen to your heart rate slow down.
And that's probably why they integrate why mindfulness practices and meditation work so well, because those deep breathings helps activate your parasympathetic nervous system.
Yeah, I believe so.
That makes a lot of sense.
Yeah.
Okay.
So we actually counsel patients in how to get into that parasympathetic state while they're waiting for the ketamine to kick in. Then eventually they're going to feel the ketamine, and the effect or the dissociative experience is going to build until they're clearly in that dissociative space.
And when they're in that dissociative space, are they seeing things that usually aren't there? Are they, I guess, transported into another realm like people report on DMT? I guess, is it just a black void? What do they report back? Visualizations, sounds?
People typically describe visuals. I wouldn't say hallucinations, but they'll describe moving patterns oftentimes. Some people describe very colorful displays. We have occasionally people will visit like relatives or other experiences, but most commonly I would say it's mostly just visual patterns, you know.
So like if you rub your eyes while they're closed, you can see all those different colors start to form. It's like that, but kind of amplified and without having to rub your eyes.
Yeah, and I would say a little more concrete.
Okay.
And sometimes the sense of movement, you know, of those visual patterns, it tends to be pleasant. I mean, if you understand that ketamine is a party drug, unfortunately, and it gets a bad name, it gets a bad reputation because it's a party drug. And in these days of fentanyl overdoses, I would be very cautious. And it's also known that recreational ketamine does not provide the same benefits of ketamine in a clinical setting.
Similar, just like psychedelics, like mushrooms, acid, it doesn't. And I'd imagine another reason why is if it's for a party setting and not a clinical setting, you don't have that introduction of, okay, accept what's going to happen, it's in your brain, all of that kind of base, how to go into it.
Right.
That might have an effect. Okay. How much does it cost? And is there insurance involved in it?
Insurance doesn't cover racemic ketamine. It does cover, some insurances will cover what's known as Spravato.
Okay.
So a lot of molecules in nature have what we call a chirality or a handedness. I explain it by telling the patient, you know, like if you looked at a pair of gloves, you'd say those are both the same glove. You know, a green glove with a red stripe. But in fact, you know, one only fits the right hand and one only fits the left hand. That's known as chirality. So the ketamine we provide in an infusion is what's known as racemic ketamine. It has both molecules, the S and the R molecules. The R molecule is actually the one that's more effective for treating depression. The S enantiomer, the S molecule, is the one that was approved by the FDA. So it doesn't have the same degree of efficacy, and it's also provided in a nasal administration, which is less effective. We've had clients come in after having Spravato treatments and just say it didn't really do anything for them. Some patients do, thankfully, get benefit, and being able to do a nasal is much more appealing for a lot of people than having an IV, but sadly it doesn't have the same efficacy rate.
Okay. It's not a psychedelic, it's not hallucinations. People might see more vividly. What are stories that people report, and can they hear you when you're talking to them while they're under the experience?
Ketamine for this use is at a very low dose compared to an anesthesia dose.
Okay.
At an anesthesia dose, you could probably talk and poke them and they wouldn't be aware. But in the doses that we use in the clinic, they're much lower. So it's enough to provide the benefits of that dissociative experience. And I should probably qualify. Some clinics do not nurture this dissociative experience. I mean, I could put you under fluorescent lights with the TV going and a blood pressure cuff on your arm and coming up and poking you every once in a while and say, "Hey, Ken, how you doing? You doing okay? Are things good?" But it's horribly disruptive and it's unwelcome to anybody who's in that dissociative space. So yes, they can. What I tell patients is that you're going to have control through the whole experience. If you need to call the nurse and say you need to go to the bathroom, you have that capability. So you're not incapacitated, you're simply in a dissociative space.
You still know where you are, you know your name, you're not just completely lost in a zombie. Right?
You probably forget where you are. You know, what I tell patients is that if at any time you have any degree of anxiety, you know, and usually the first time it's such a bizarre experience, that they'll feel the need to check in with reality, or what we call ground. They'll need to ground. So if they just open their eyes and say, okay, I'm in the clinic, I do still have hands, I can still move, I'm getting an IV, I'm where I'm supposed to be, everything's cool, and then we encourage them to go right back into that dissociative space.
Yeah, personal story, I took I would say, a relatively high dose of mushrooms, psychedelic mushrooms. And that was one thing. I blindfolded myself so I could try to get that full visual experience. But when I did start to I tried to make my heart rate go up and try to have a bad trip, which was pretty interesting just to see, because everything was going well. And then as soon as I was able to start to get my heart rate up and get some anxiety flowing, I just took my blindfold off and looked at myself, and I was like, oh, everything is okay. It's just all happening up here, in a sense. So how many of your patients would say they've already tried it at a party setting, or they've tried other psychedelics, and is this their first time trying something like this for the most part?
I would say to the degree that patients reveal such information to me, it's less than 5, even probably 3%, maybe 2%. Like if I think of over the last year, I would say maybe 3 or 4 clients, maybe 5 have admitted to having non-clinical ketamine experience.
And what age range would you say your patients are? Are they all super old, or some of them in their 20s? What's the range? Is it just everybody?
It's pretty much everybody. We've had clients or parents call to have their kids treated, but we don't treat anyone less than 15. And then I've had clients in their 80s. So it's depression affects everybody, anxiety affects everybody, PTSD affects everybody. And so we get the full range.
Someone goes through their first session, they go through all their sessions. What's their journey getting off of ketamine therapy and just living their life? What's their roadmap?
I would say, so if you're coming in for PTSD, oftentimes between the ketamine and the magic, the ethereal nature of the dissociative experience, some people work out a lot of their issues during the induction series, and oftentimes don't feel too much of a need for a very intensive maintenance program. But I would say for depression, anxiety, the average client sticks with us for about a year and a half, give or take. We've had some patients that have been with us since we opened back in 2017, but most people undergo ketamine for a while, and then what I believe happens, and I don't have any studies to validate this, but I believe once they're in a better place, we all undergo neuroplastic change every day. We used to believe that neuroplasticity stopped in like the late teens, early 20s, and the brain didn't change anymore after that. We know that that's not the case. Our brains are always rewiring. They just don't do it as fast anymore. When you view yourself as no longer depressed, your interactions with other people, with your environment, is as a non-depressed person, that neuroplasticity eventually gets to a point where I don't believe the patients need to rely on the ketamine to maintain those benefits anymore. I talk to them about going off ketamine, they go off, and the great majority we never see again. Every once in a while, I would say since we started, I've had less than 10 clients come back and wish to reinitiate ketamine therapy.
That is huge.
Now, undoubtedly, there are some lost. Some may feel like they need to come back, but they don't. Some have probably moved. So I'm not saying that it's that successful, but given that, they know where to come back to and they don't, and that's we see so few ever come back.
Yeah, I mean, just from basically every personal anecdote I've heard of people on antidepressants, staying on for a year and a half and then being done?
Unusual.
That's unusual. That is very unusual. So we like ketamine therapy because of how it's different, I guess, neurologically, biologically, how it acts on the brain. But we're also saying this dissociative process has a huge impact. And I'd imagine besides just the brain fertilizer, like you said, that ketamine helps with, I'd imagine in this dissociative state, it does something to the language of the individual, however that might be. We don't really understand that yet. but like you're saying, they cease to identify with their depression. So to me, that signals some form of language shift. How do you see people's language shift before and after ketamine therapy? Is there anything that you typically notice? Anything that people usually say? Or
one of the really rewarding and fun things, I when I started surgery, I did trauma surgery. And so I used to say kind of dramatically that I used to snatch people from the clutches of death. And literally, I mean, when somebody comes in with a fractured spleen, a fractured liver, and you don't stop that bleeding immediately, they're going to be dead in no time. Mm-hmm. And I've done that. And I've cut out cancers, and I did bariatric surgery for a long time, which was rewarding. People who struggle with obesity can't lose the weight, and then in a year they've lost 130 pounds. But ketamine work is the most rewarding work I've ever done, because depression is the number one cause of disability in the United States. A lot of people have struggled with depression since their teenage years, and they're coming to see us at 40 or 50. And what I was getting at is it's so rewarding because even the receptionist, Catherine, can watch people, how they come through the door to begin therapy. And as they walk through the door, we can see the changes in them without even talking to them. Okay. But then, of course, they repeat their stories or report their stories about how life has changed and how grateful they are and such. So it's a very significant transformation, and you don't have to necessarily be trained in ketamine or talk to the patient to see the benefits.
So you were saying you were a surgeon. I myself had a spleen incident and an appendix incident. I'm missing both now. So much respect for you on that route, being a surgeon. But why did you transition from being a surgeon in the most traditional pharmaceutical, I guess, kind of practice there is, to then this super new age, hippy-dippy, but not hippy-dippy because there's a lot of science in it, kind of medicine? What made that transition? How did you have that life journey?
I actually went into surgery for the wrong reasons. I thought I was going to go into emergency medicine, and I always loved physiology. And you're never supposed to have a plan B if you're really committed to plan A. Burn your ships kind of mentality. Yeah. So I was going to study optimizing athletic performance. But so again, I really enjoyed biochemistry and physiology. But in going through medical school, I was recognized as having some skills and motivation, and so I was strongly encouraged by several of my attending colleagues, mentors, to go in surgery. I got an award for best, let's just say there was a lot that pushed me into surgery, and I was just young enough and kind of silly or naive enough to listen to them instead of my own heart. So I went into surgery, and then once you're doing something and it's the only thing you're trained for and you're making a good living, the idea of changing gears and doing something else is very difficult. Very difficult. And so I kind of managed in surgery for a lot of years before I found my way out. And basically I was just like, I had reached a point where I had to do something else. And so I thought it was going to be naturopathic medicine. I thought I was going to go back to naturopathic school. And I started in reading options. I learned about functional medicine, getting to the root cause, and that just had massive appeal to me. That's what I'd always looked at doing for myself and my family. And so I went back to school for functional medicine. And along that transition time in Nevada, AB 474 came down the pike, during the opiate crisis, and they were really putting restrictions on opiate prescribing. And so still practicing as a surgeon, I started looking for alternatives for pain management. At the same time, a colleague of mine in emergency medicine was looking at the same thing, and we would get together for dinner, and we started discussing ketamine, and it was his idea to open up a ketamine clinic, which I had not even heard of. And I thought it was a great idea and possibly a way out of surgery, in addition to functional medicine. So we opened up the clinic together. That lasted for, I don't even know, before he lost interest and I bought him out. And so now it's a solo thing, the Ketamine Clinic here. Dang. But the move out of surgery was it was very scary, but I couldn't be happier.
Yeah, what made that final decision of, all right, this is too much, I need to start looking for something?
Once I found functional medicine and opened the Ketamine Clinic, there was no looking back.
Okay.
Then it was just slowly putting the things in place to make it happen.
What's your best success, and then what might be the worst failure?
Oh gosh, picking the big success would be a challenge. There's just
All of them, probably. Every success is the greatest.
Yeah, I mean, there's some dramatic stories, that I get to know a little more of the backstory. A couple PTSD stories. We had a military vet. He had done 6 tours in the Middle East, seen horrible things, crippling PTSD. He came in, his wife basically told him, look, I love you, but I can't continue to live like this. You've got to get some treatment. And they came in not knowing what to expect from ketamine. And he had a successful treatment, and I understand that within just weeks, months, his marriage was solid. He was employed again. We have another female who had been assaulted. She already had PTSD from her late teens, early 20s, and then she was at the concert in Las Vegas about 6 years ago, the Jason
October
Aldean
1st.
concert.
Yeah.
And my understanding is that she was pinned down for about 2 hours, just basically waiting for her chance to die. Her turn, really.
Yeah. Yeah.
Horribly traumatized, incapacitated essentially afterwards. She had had a drug use history, and so she was really scared to engage in ketamine because of its history as a party drug. But she and her husband eventually agreed that it was worth a shot, and it completely turned her around. And now she actually acts as an advocate. She has the biggest heart you could ask for. She's a beautiful, giving human being, and she basically tells other people, and she's told me, like, if your clients have questions and they want to talk to somebody about ketamine therapy for their PTSD, have them call me.
So not just depression, we also see ketamine therapy working for PTSD. What else does it work for?
Anxiety, OCD, bipolar disease. There aren't papers demonstrating it, but it's being looked at now for means of like neuroprotection, so preventing against cognitive decline. Alzheimer's disease, is one of the biggest, ones that everyone's scared of.
Yeah.
It has a significant impact on families' quality of life, the healthcare budget.
Now we're done with the ketamine. What else can someone do in their life to help this brain fertilizer, to help with their neuroplasticity, to stay healthy? What else can they do besides diet and exercise? Or is that really it? Diet, exercise, maybe find a purpose in life that's bigger than yourself? What else is there?
Yeah, actually, one of my questions on the intake questionnaire is, do you feel like you have a purpose in life? It's a big component, but excuse me. First and foremost are going to be diet and exercise. But as we talked about, chronic cortisol exposure precipitates or leads a good number of people to depression. And if you can, so in the functional medicine side, I have what I call foundational principles or core behavioral aspects, things that are important for optimal health, which and the brain and the body are not separate. We treat them as separate entities, but if you take care of your body, you're going to be taking care of your mind. And so exercise, vigorous exercise, and just kind of zone 2 long-term exercise, like 45 minutes an hour a couple of times a week. I'm sorry.
No problem.
We'll have to edit that out. Diet, exercise, stress mitigation. So a mindfulness practice, meditation practice, walking in the woods, exercising, vagal exercises, breathing exercises. There's a lot of things that you can do to mitigate stress. First is extricate yourself from a stressful situation if you can.
Yeah.
Oftentimes we don't have that option, so you need to find ways of getting your cortisol levels down, spending more time in that parasympathetic space relative, to the sympathetic space. And then toxins. We live in a toxic soup. The environmental working group did a study on babies. The minute they were born, they tested their blood for over 500 common toxins in the environment. On average, these babies had over 280 chemicals in their blood the minute they're born. And this plays a significant role in obesity and cognitive decline, and I believe depression as well. So if you can manage all of those, which isn't that difficult, you don't do it overnight, but over a series of weeks and months with a constant attention, all of these things are going to contribute to your mental health.
So it's not just drugs. We take a whole Gestalt approach, and it's not, here's this thing, you're fixed, you're done. You're not fixed. There's not really something wrong with the person. A functional approach says you're functioning how you would in this environment given all these factors. So let's change some of these factors. Let's get you with this new skill. Let's maybe help a little bit with this drug to help. But it's a lifestyle change, which I'd say most mental health practitioners who just give drugs don't focus on. And so that is a huge focus here.
Yeah, and in their defense, I don't, most of them aren't trained to do this kind of work.
Yeah.
I'm happy to say that that's something that I went back to school for and have always enjoyed and thrive on now. And I want to also point out that a lot of people do the right things. They are eating a clean diet, they're exercising, they're managing their stress, they're taking what I call foundational supplements that account for the common nutritional deficiencies that we see. And they're doing their very best, and they still struggle with depression. There's a lot about depression that we still don't understand. But there are so many people out there that can do much more for themselves, but they're not being counseled. They don't know what they need to do.
So for maybe 80% of the population, diet, exercise, purpose, and ways to get yourself out of a stressful environment and to do kind of anything to help activate your parasympathetic nervous system. 80% of people, they're going to be golden, but then there's those 20% that we still don't know why they're not doing better. And that's where we need more research.
Yeah, and whether it's 20% or 15% or 30%, I don't know, but I think the bottom line for everybody, and if you're doing those things, you're not just going to reduce your risk of depression and anxiety, you're going to reduce your risk of cardiovascular disease, cognitive decline, hypertension, take your pick.
Is there anything else, ketamine related, pharmaceutical related, mental health, anything related that you want to end on?
I don't know what it would be. I would just say, for the people that are uninitiated and place all their faith in the pharmaceutical allopathic world, that there's a lot more that they can do for their own health than relying on the system. The system is broken. I mean, I think probably everybody knows that, but it's very broken. One of the most impressive things I remember going through school, and I see it repeatedly, is when they take geriatric patients, older patients, and they're specially trained geriatric doctors. And one of the first things they'll often do is just start taking patients off the medications and see how much those patients improve. Cognitive function, quality of life comes back. So there's much more that people can do than just relying on their doctor and drugs.
Beautiful. I appreciate the time you took, Dr. Bob. Appreciate it. Do you want to give where the Well-Centric Clinic is located here in Reno, the address? I guess who to get in contact with?
Sure. It's Well-Centric Health. We're at 6880 South McCarran Boulevard, Suite 12, so kind of centrally located. And just give us a call, 323-75, excuse me, those are the old days, 335-2044. 335-2044.
775 is the area code.
Yes, 775-335-2044, and you'll speak with Catherine or Tina. We have a very small staff, possibly Michelle, and it's that simple. You just say you want to come in, and we'll get you booked.
Can people from out of state come in if they wanted? If someone sees this in New York or a state where maybe it's not legal or they don't have something in their area, can someone come out of state?
Absolutely. We actually have a significant contingency of out of state clients.
Cool. Well, all right. Thank you again. I appreciate it.
My pleasure, Ken.
What's going on, guys? Thanks for checking out my channel. Be sure to hit that subscribe button and make sure to turn on notifications so you can see when I post again. See you next time.